So Nis asked me just a quick talk on acute coronary syndromes. It's something that is common in exams, it's common in real life, and it's quite serious as well. So it's worth knowing a little bit about. We got asked about it in our finals. So hopefully this is useful. It's kind of geared towards what you need to know as an F1 and what could come up in finals. Hopefully it'll be okay. If there's any questions, just pop in the chat or shout out. We've got a couple of SBAs and cases as well at the end. So yeah, let's get started. This is just a little bit about me. Started on F1 this year and I'm working on cardiology. So hopefully I can teach you some useful stuff. But by no means an expert. So if I don't know the answer to a question, I can always point you somewhere else that can be helpful. So let's just start with what we're going to go through today. So we're going to start with a couple of SPAs just to kind of see what we know and what we're going to go over in the chat, in the talk. Then go through what actually is, go through how to spot it and with tests, how to treat it, what might go wrong, and then finish off with some cases which hopefully can kind of reinforce what we've learned. Here's the first SBA. This is kind of a bit of basic science about ACS. So I think Nis has got a poll that he can get going. I'll give you guys a couple of minutes to read it, and there we go.
I'll launch the poll. Can everyone see the poll? Yeah, I'm getting answers, so I'm guessing everyone can see the poll now. If there are any issues with the poll, you can always put it in the chat. And the poll is anonymous, so just give it a shot.
Yeah, we'll go through why stuff is right and wrong as well, so no worries if you don't know. We'll go through this all in the talk as well.
I'll give you guys about a minute. So there's a good array of answers, so it's kind of good. There's
It'll be perfect.
I'll
explain types of MI as well throughout the talk. Don't worry. That comes up very soon, actually, kind of one step ahead of me. Yeah.
Right, I'll end the poll now. If you guys, yeah.
Cool.
And I'll share the results.
So thanks very much for voting, guys. So the correct answer for this is A. And the reason is, we'll go through the talk later, is that ACS is defined basically by a rupture of a coronary plaque. There are other rarer causes, which we'll go through, but this is the main one to know about. It's not B. So troponin is an enzyme that's released when cardiac cells die, which is defined as an infarction. And an end-STEMI and a STEMI are both types of infarction. So both of them cause a raised troponin. Number 3, a normal coronary angiogram rules out ACS. Similarly to answer A is incorrect because there are other causes of ACS that aren't necessarily narrowed arteries and ruptured plaques. So just because you've got a normal coronary angiogram doesn't mean that your vessels are healthy. So, I don't think anyone voted D, so well done. Males are much more likely to show the classical symptoms of ACS, like the crushing chest pain going to the jaw. Females are more likely to show present with no chest pain, in fact. And E, a STEMI presents exclusively with ST elevation. So STEMIs obviously do present with ST elevation, but there are a few other things that they can have on ECGs, which are a bit rarer, but important to know about. And we'll go through them throughout the talk. Lovely. So number 2, this is a bit more of a case, kind of a bit more management investigations wise. So again, have a read of this one, a couple of minutes, and give you a let's go.
I'll give you guys a little longer on this bit longer case.
Yeah, take your time.
I'll give you guys about 10-15 seconds. I think most people are answering now.
Yeah, B and
That's
D
what
seem to
we
be in the
answered.
lead, and I've just read answers though.
Yeah. All right. I'll end the polls now. Share the results.
So there are the results. So the correct answer to this one is E. So let's go through them in order. This is probably the best way to do it. So A, he is suffering from unstable angina. Remember what we said about how troponin is released when cells infarct or they die. In unstable angina, there's no death of any cardiac cells, so the troponin isn't released. This guy's troponin is sky high, so that's why he's got not unstable angina. He's got what's called an N-STEMI. B, the pathology most likely involves the left anterior descending artery. So this is incorrect because you need to look at the ECG leads which are affected. So the left anterior descending artery is represented by leads V1, 2, 3, and 4 on an ECG, which is the front side of the heart or the anterior side. He's got changes in leads 2, 3, and AVF, which are the inferior leads of the heart, which is supplied most commonly by the right coronary artery. So this is something that we'll see all the time in ECGs with ACS, and it's important to know. I don't think anyone voted C. His troponin is sky high, and we'll talk about kind of how to differentiate between different troponin results a bit later, so well done. A few people voted D. So he does need PCI at some point, but not immediately. So in an N-STEMI, you can wait a little bit longer. In a STEMI, you need to do PCI kind of ASAP because it's quite dangerous. But an N-STEMI is less fatal in the meantime. So you can afford to wait a little bit, basically. And lastly, E. So this is correct because these 4 drugs here, so an ACE inhibitor, beta blocker, dual antiplatelets, and a high-dose statin, these are drugs that we give to everyone after they've had ACS. And these help improve your mortality by various different mechanisms, which we'll go through a little bit later. Lovely. So the PCI cutoffs. What do you mean by that? Is that in terms of like time? Yeah, so time-wise, we'll go through it later. But in a STEMI, it's typically 12 hours after the chest pain starts. And in N-STEMI and unstable angina, it's 3 days. And we'll go through why that is a little bit later as well. Hopefully that makes sense. So those are a couple of little taster questions to start things off. So what actually is ACS? Let's go back to basics. So the top photo on the right-hand side is a normal, healthy coronary artery. Lots of blood can get to the heart. There's no limitation of myocardial perfusion. It gets all the oxygen it needs, and the heart is nice and healthy. The middle photo is what's called stable coronary syndromes. So this is something like stable angina. This is when there's a plaque narrowing the artery and narrowing the amount of blood that gets through to the heart muscle. This means that at rest, the heart gets enough blood, but when you exert and the heart demands more oxygen, there's not enough blood to supply the oxygen it needs, so you get chest pain on exertion, which is stable angina. The bottom photo represents what's happening in an ACS. So this is when the plaque ruptures, and this can happen at any time. It can happen at rest or at exercise, but most of the time it's at rest. We don't really know why they rupture, but they tend to randomly, basically. And the plaque ruptures, the endothelium, the lining is disrupted, and platelet activation and the coagulation cascade activates as well. So you get a clot that blocks off the blood supply to the artery, and that's why you get this chest pain at rest in an acute coronary syndrome. Lovely. So an ACS is represented in 3 different clinical ways, basically, going from least bad to bad. So number 1 is unstable angina. All of them involve, most of the time, this plaque rupture. In unstable angina, there's still enough blood getting through the rupture for you to have some supply to the heart muscle, so the heart doesn't die. N-STEMI, there's less blood, but there is still some blood going through. So some cells die, but not the full thickness of the myocardium, which is what causes ST depression and T-wave inversion from an ECG. And lastly, the STEMI, which is when there's no blood getting through, your artery is completely blocked off, and your heart is just knackered, basically. It doesn't have any blood, and the heart cells die. And the full thickness infarct of the myocardium is what causes ST elevation on the ECG. So we mentioned at the start that most of the time the pathology is a plaque rupture, but sometimes, most of the time in younger people, there can be other rarer causes. So commonly what we see on the ward is young blokes who have been taking lots of coke, and that causes your coronary arteries to spasm. And it's the same effect of a plaque rupture, basically. Your heart can't get any blood, and the cells die. So that's why you can have a normal coronary angiogram but still have ACS. Another fairly common cause is emboli from AF. So these most of the time go up to the brain and cause strokes, which I'm sure you've heard about before, but very rarely they can go into the coronaries and block off the coronary arteries without any plaques. So basically the message there is just because someone's not old, they don't smoke, etc., etc., they could still have ACS if the chest pain sounds typical and the blood tests and the ECGs look right. So that's what ACS is. Now, how do we spot ACS? So there are some very classic symptoms of ACS, which are nice and easy to recognize. So you get this central crushing chest pain radiating to the arms and the jaw. It's very severe, 9 to 10 out of 10. And it's not relieved by their normal GTN spray that they have for their angina. When you hear this pain, this is what's called ischemic chest pain, and there should be ringing bells basically for something going on in your heart. Something that's really important with ACS is that you get what's called autonomic features. So this is nausea, you sweat, you feel anxious, you look pale. And these are really important to notice because you can't fake these. If you've got chest pain, you can think that it might sound a little bit ischemic, it sounds crushing, the history can be a little bit vague. But if someone's sweating, they're pale, they're nauseous, they're vomiting, that shows you that something basically bad is going on. It's an important thing to talk about in your history. And lastly, we talked about this in the first SPA, is about silent MIs. So these are really important to recognise as well, and previously were under-recognised. So these are more common in diabetics, elderly people and women. And this is when you get an MI without chest pain. It's a bit weird, but you just basically get these autonomic features that happen suddenly. So someone might get sudden onset nausea, sweating, feeling crap. They might get some tummy pain. And in people like this, it's just on your radar to do an ECG because it might be an MI. It takes 2 seconds to do an ECG, and you might have just stopped someone from having a heart attack. So they're the symptoms. They're the main way you make the diagnosis clinically. There aren't really any signs in ACS, apart from the autonomic features that we talked about before. What you're kind of looking for now the diagnosis is a lack of signs. So if you, for example, had, I don't know, no air entry on one side of your chest, that would mean maybe there's something going on in your lungs, a pneumothorax or a pleural effusion. In ACS, normally you have a normal physical examination, which again, although it isn't anything positive, points to ACS as a diagnosis. So those are the symptoms. How do we diagnose it on tests now? So we've got someone who we think might have ACS with this ischemic sounding chest pain. So you do two things. Firstly, you do an ECG, and secondly, you think about doing a troponin blood test. So let's talk about ECGs first. ECGs and ACS are simple once you get the basics of them down, basically. An important thing to know about them and how to diagnose ACS is that the changes are what we call territorial. So we talked in the first SPA or the second SPA about different leads being supplied by different arteries of the heart. And this is what this picture here shows. So you can see here, so the bloke at the start, he had changes in leads 2, 3, and AVF. These are the leads that look at the underside of the heart, so the inferior border. And this is supplied most of the time by the right coronary artery. So if this artery is blocked, you're going to get changes in these 3 leads. Similarly, in the LAD, so the big one, this supplies about half of the left ventricle, which is the front of the heart, the anterior side. This is represented by V1 to V4. So if your LAD is blocked, you'll get changes in these leads. And lastly is your circumflex artery, which comes off of your left main stem. And this is represented by the lateral leads. This is AVL, V5, and V6. I've just seen a good question. Why does it radiate to the left arm of the jaw? And Niz, you're spot on. Yeah, it's because of your dermatomes and things like that. It's because the heart is supplied by your T1 to T4 and the cervical roots. So if you've got irritation there, it spreads to your skin nerves, basically. Or I don't know, it doesn't sound very technical, but that's why you get it spreads to the dermatomes of T1 to T4, which is your arm, and up to your neck as well. So very good. So that's the territorial nature of ECG changes in ACS. The second thing to note is that they're dynamic. So what that means is that they change over time. Loads of things can cause ST depression and T-wave inversion in ECGs. But in ACS, what you get is the changes getting worse and better over time as more cells die or as the cells recover from ischemic injury. So one of the keys that you need to do is you need to do ECGs every single day on someone who's had a heart attack to see if they're getting worse or getting better. And that's something that we'll talk about on the next slide. So that's the basics of ECGs in ACS, the principles you need to understand. Let's talk about what we see in STEMIs. So STEMIs are nice and easy. You get ST elevation, basically. So over seconds to minutes, you get ST elevation. So this is your ST segment on the left-hand side. It's nice and flat. Your ST segment rises within a couple of minutes in the leads representing the artery that's blocked off. And it's defined as a rise of, I think, more than 2 small squares in the chest leads and 1 in the limb leads. So 1, 2, AVL and AVF. The changes then are dynamic and happen over time, so they get worse, basically. The next change that's important to know about is what's called a Q wave. So you can see here, on the left-hand side, your QRS complex goes sharply up. This is normal. A Q wave is when the first deflection in the QRS complex goes down. And this is indicating that you've had an MI that's been there for some time. And these stay there forever, basically, once you've had an MI. So there's something to look at on an ECG. The next day or two, you get some T-wave inversion. And after that, the changes kind of get better over days. So this is why the ECG changes are really, really important to keep monitoring every single day, so you can see what stage people are at of their heart attack. Because if someone's come in, let's say they're a guy who doesn't live near a hospital, they don't like doctors, they come in with 2 days of chest pain and they've got some T-wave inversion. It doesn't mean that they've not had a STEMI. It means that you might have just missed the boat, basically. It's important to be aware of that stuff. So that's ST elevation. There are times when you can have a STEMI and you don't get ST elevation. So can anyone tell me what they think is going on this ECG? The troponin rise, I'll talk about later. Good question, good question. So seeing some answers. Yeah, it seems like most of you guys have got it spot on. ST depression, turn the ECG around. Yeah, perfect. So this is what a posterior STEMI looks like on an ECG. So we talked about how the ECG, a 12-lead ECG, only looks at the front, the side, and the underside of the heart. It doesn't have any leads that look at the back of the heart. So what we get, when you get a posterior STEMI, the backside of the heart dies. There's nowhere to sense that directly on the ECG. So what you get is what's called reciprocal changes, which is when you get stuff that's upside down on the other side of the ECG. So that's shown very nicely on this ECG. So we talked about how V1, 2, 3, and 4 represent the front of the heart. And if you were to have a STEMI in that bit of the heart, you get ST elevation, you get T-wave inversion, and you get Q waves. If you have a STEMI on the back of your heart, instead of ST depression in ST elevation, you get ST depression because it's mirrored. Instead of Q waves, so the first deflection going down, you get really tall R waves. So these are the ones that you can see mainly in V3 here. These wouldn't have been as tall on this old ECG. And that's basically the upside down Q wave. And instead of T-wave inversion over time, you get these really sharp risen T waves. And these are all basically upside down changes, mirror image. And why can't this be an NSTEMI? That's a good question. This could be an NSTEMI, and it's very difficult to tell between a posterior MI, a STEMI, and an NSTEMI. What you'd be looking for to differentiate this between a posterior STEMI and an NSTEMI is, number one, you get the tall R waves, which are new. You wouldn't get that in an NSTEMI, you just get the ST depression. And in an NSTEMI, you probably get some T-wave flattening and some T-wave inversion, whereas in this, you get the T-waves going sharply upright. And yeah, so you're spot on. So you can do what's called V7 to V9. So these are what's called the posterior chest leads. And these are just chest leads that go on your back, and it shows you ST elevation because they look at the back side of the heart. I've never really seen these done. I think they can do it on CCU. It's something to be aware of. But yeah, V7 to V9 are to kind of keep in mind. Posterior STEMIs aren't very common. It's just something to be aware of. So that's ST elevation and posterior STEMIs. There's one more way an ECG, a STEMI can present on an ECG, which is, if I can click, new left bundle branch block. So this is a very typical pattern that you'll see in ECGs. There's a wide QRS complex, there's T-wave inversion in some of the lateral leads, and you get these really deep, broad QRS complexes with some ST elevation. This is left bundle branch block. And what this means is that the left bundle branch, so the bit of electrical wiring that supplies the left ventricle, is basically knackered. It's really common. It happens loads in hypertension, in old age, arrhythmias, chronic angina, and also in ACS like STEMIs. So if you do someone's ECG 10 minutes ago and it's normal, they've got chest pain, and you see this, what it means is that something's gone on in the heart over 10 minutes to completely knacker your left bundle branch. And what means is that the heart muscle has probably died from a full thickness infarct, i.e. a STEMI. So that's fairly simple. A new left bundle branch block is a STEMI until proven otherwise. But the problem arises is when you have an old left bundle branch block. I'll talk about the left bundle versus right bundle in a little bit later after we've done the old left bundle branch block. I'll get your question, don't worry. So yeah, new left bundle branch block is really easy, but old left bundle branch block is difficult because we can see that in left bundle branch block, you already have some ST elevation. You can see here in V1 through to V4. You already have what look like Q waves. So you can't just tell that someone's got ST elevation if they've already got left bundle branch block and you do an ECG and it's still left bundle branch block. So what you do, you can do something called the Scar-Bossa criteria. I don't think you'll get asked about these in finals. It's something that's probably a little bit mean, but it's something to be aware of. And it's really useful because it helps you tell when someone's having a STEMI who's already got left bundle branch block. So let's go through them in turn. Number one is concordant ST elevation more than 1 millimeter. What this means is that when the QRS complexes, so you can see on the left-hand side, go up, if the ST segment is also elevated more than 1 millimeter, it's bad news. You basically have an MI. So let's look at this left bundle here. Look at lead 1, top left. You can see that the QRS complex has gone up, and in normal left bundle branch block, you have some ST depression. This is what you would expect. If you have new ST elevation when the QRS is also going up, that's bad news. Number two is when you get ST depression in V1 to V3. So let's go back to this ECG here. You can see in V1 to V3, you have ST elevation. This is normal in left bundle branch block. You can't comment on that. What would be worrying is if your ST segments in V1 to V3 were newly depressed. That would mean that there might be another infarct happening and would raise your suspicions of an MI. And lastly is what we call discordant ST elevation, more than 5 millimeters. So let's go back to this ECG. Look at V1 to V3 again. V1 to V3, we can see that there is ST elevation and it's discordant. What means that the QRS complexes are pointing downwards and the ST elevation is going upwards, so they're going the opposite way. But what's not worrying is that it's less than 5 millimeters, so it's less than one big square. If you had ST elevation, as we can see here, and it's more than one big square, that might mean that there's an MI going on. Okay, so I don't think you need to learn that off by heart. It's something to probably just look. I don't even know. I just Google it on the wall, to be honest with you. You've probably got 30 seconds in real life to Google it. But if you know about the Scar-Bossa criteria, it's useful and you'll look really smart. So why not? So I think someone asked a question about left bundle versus right bundle branch block. How many points is regarded as a STEMI? I can't remember. I would just like plug it into MedCalc and it will do it for you. So I'm sorry I can't answer your question. It tells you that it's not really that common, and I kind of am only just about aware of it, to be honest with you. So we got asked left bundle versus right bundle branch block. So the classic thing that people talk about is William and Marrow. So what that means is William is left bundle branch block because William has L's in the name. It's just like a little acronym. And what that means is you get a W in the chest lead, in some of the more right-hand side chest leads. So you can AVR, you've got a little W. And you get an M, so W and then M for William in the last leads. So you can see here it looks like an M. That's left bundle branch block, basically. And it's just all about pattern recognition, the pathophysiology. There are reasons for this, but it's just about kind of knowing how to recognize it, basically. Right bundle branch block looks a bit different, and you get what's called like a little RSR pattern in leads 1 to V4, which is like a little squiggle. And it's just something to Google and pattern recognition, basically. I don't have a photo of it, unfortunately, but just kind of burn it into your brain. And Empatel has been very useful, and told us how to use the Scar-Bolter criteria. Thank you very much. I should probably know that before this talk started, but thank you very much. Lovely. So that is a STEMI on an ECG. Nice and simple. Number 1, ST elevation, which is what 99% of your stuff's going to be. Number 2, posterior STEMI, and number 3, left bundle branch block using your Scar-Bolter criteria. And then you've got your diagnosis. You've got the ECG, it's got a STEMI, you don't need any more blood tests, you can just get on with treating. So what about unstable angina and NSTEMIs? So these are a little bit more tricky. They both share the same ECG features. So you get changes that represent ischemia or full or partial thickness infarction of the myocardium. And this manifests as ST depression, which is on the bottom left-hand side. I don't know what this upsloping and downsloping is. It's just the ST segment is depressed. That's enough to know. And T-wave inversion or T-wave flattening. We can see here that the flat T-waves in the top right and inverted T-waves on the bottom right. And this represents both an NSTEMI and an unstable angina. So you can't tell them apart on an ECG, basically. Also, rarely you can have no changes. I don't know why, but you can sometimes have no changes. But this is when you kind of need to think a little bit more about what's going on, basically. So it's tricky for a few reasons. Number 1, the ECG changes are the same. Number 2, as I think a question brought up earlier, is that loads of things can cause T-wave inversion. So for example, an old STEMI can cause T-wave inversion. The way you would tell the difference would be the time frame. So a STEMI has T-wave inversion after a few hours, after a few days, sorry, whereas unstable angina and NSTEMI cause T-wave inversion right away. Loads of things cause T-wave inversion that is there all the time. So PEs, left ventricular hypertrophy, left bundle branch block. The difference between this and unstable angina and an NSTEMI is that you get what's called dynamic changes. So they change over time. So the T-wave inversion might get better or might get worse depending on if cells are dying or if they're not. If the T-wave changes stay there forever, that probably means that it's not an ACS. Okay. And number 3, there might be no ECG changes. So how do we go about telling someone's got some ischemic sounding chest pain? ECG is a little bit, you don't really know what's going on. There's some T-wave inversion. Could be unstable angina, could be an NSTEMI, could be nothing. You do what's called troponin. So we talked about troponin a little bit at the start of the talk. Troponin is an enzyme released when myocardium dies. So i.e. in an NSTEMI or STEMI. It's not released in unstable angina because there aren't any death of the myocardial cells. When myocardium dies, what you get is represented by the red line on this graph. So you get a very sharp rise in your troponin that can go up into thousands and tens of thousands. It's like off the scale. And it settles slowly over 2 weeks. And the use of that is what you can do is you can do repeat measurements of your troponin to show that cells are actively dying. So let's say you take a troponin, it's a little bit raised. It could be some other things as well, which we'll talk about in a little bit. What you can do to confirm your diagnosis is wait 3 hours, do it again, and if your troponin shot up, it means that there's still cells dying and more troponin's leaking into your blood. which indicates an acute coronary syndrome, i.e. an STEMI or a STEMI. The difficulty with troponin comes with the fact that other things also raise your troponin. So anything that strains your heart muscle raises your troponin. I'm not sure why, but PEs, if they're big enough, heart failure, arrhythmias, pericarditis, all raise your troponin. Troponin's eliminated in the kidneys. So if you've got CKD or an AKI, you can have high troponin because you're not clearing it from your blood. The difference is that these causes down here don't cause this rise and fall in your troponin as ACS does. So this is where the value of repeat troponin measurements comes in really, really handy when you're not sure what's going on. So if you do a troponin and it's a little bit raised, you see where these two lines intersect. It could be anything basically. You repeat it in 3 hours and you see if it's shot up, that means that some cells are still dying and it's probably an NSTEMI or a STEMI. And if the troponin's about the same, it might have gone up a tiny bit or it might have gone down. It's probably something else. You don't need to worry. The value that we use to say that there's been like a proper change is 50%. Some labs it doubles because they use slightly different troponin. So I've not given exact definitions here because it's just more about the principles of how to understand troponin results basically. Now I've written here about an upper and a lower limit to troponin. So troponin is a bit of a weird blood test in that it's not just got one upper limit, like I don't know, a CRP is below 10 normally or whatever, and then if it's raised, it's raised. Troponin, at least in the labs where I work, the range is 2 to 260. And what this means is that below the lower limit, so 2, it means that there's definitely no cardiac damage. So 99% of people that they've tested, they don't have any troponin released. There's no cardiac damage, the heart's completely healthy. Above the upper limit, so again 260 in my lab, but it could be other stuff elsewhere, is indicative of cardiac damage. So there's enough troponin released that it wouldn't be one of these things here causing a mild release in troponin. It's going to be a big heart attack basically. So you don't need to repeat the troponin because you know what's going on. And that's where the value of repeat measurements come in. If the troponin's within this kind of middle range where you're not sure what's going on, if it's within the range, you repeat it in 3 hours and see if it's risen. And if it's risen sharply, so more than 50% or doubled, then you can be sure that there's an acute coronary syndrome happening, so an NSTEMI or a STEMI. Lovely. So that's troponin. It's tricky to get your head around, but really important. People do troponins all the time, and you could not treat someone for a heart attack, or you could treat someone for a heart attack wrongly if you don't know how to interpret it. So it's not about the exact values, it's more just about the principles of this rise and fall, and that other things can raise your troponin, basically. So that was a bit of a whirlwind of everything. This is it simple, which is kind of how I like stuff. It's nice and easy. So you've got someone with chest pain, sounds ischemic. You do an ECG, and they've got ST elevation. There you go, they've got a STEMI. Off you go. You do an ECG, they've got no ST elevation. They've got some ischemic sounding chest pain, some T-wave conversion, some ST depression. Could be an unstable angina or could be an NSTEMI. So you do a troponin. An NSTEMI has high troponin, and unstable angina has normal troponins. Lovely. So that's how to spot ACS. Are there any questions before we go on about how to treat ACS? Because that was quite a lot of info, appreciate. But the main principles are the important things to understand, not the exact values. What is a dynamic rise of troponin? So that is shown here by this red line on the graph. A dynamic rise means that it rises over time, basically. What we use as a definition of dynamic where I work is 50%. So if it was 100, then 150, that's a dynamic rise. In other labs, it might be doubled. It just depends on what the measurements are that they use. Whereas if it rose less than whatever your reference range is for this, it's not a dynamic rise, it's just an insignificant rise that's of no consequence. Is there a percentage cutoff? Yeah. So where I work, it's 50%. In other labs, it's 100%. If you get a question about it, they should tell you what it is. And the time frame is 3 hours. So again, that's where I work. In other labs, it's 6 hours, but most of the time it's 3 hours. Okay, so 50% over 3 hours is what we use here. Lovely. So hopefully that makes sense. No worries, no worries. So we talked about to diagnose ACS. So how do we treat ACS? The immediate management of ACS is nice and easy. It's all the same, no matter what ACS you have. An important principle with ACS treatment is that everyone gets the same stuff. They just get it over different time frames. So start with your investigations. Someone's got ischemic sounding chest pain. You do an ECG. That's the first thing you need to do. You then want to do some blood tests. So you can do a troponin if they've got some ischemic changes. You can do a lipids because this is showing risk factors for heart disease. You can do a glucose. Diabetes is another risk factor for heart disease. You do a U&E because if they need an angiogram or a PCI, they inject contrast. And if you've got knackered kidneys, you can't have any contrast. So you need to know what your baseline is, basically. You then do a full blood count because, again, when they could do an angiogram or a PCI, you can lose blood and you can bleed, so you just need to know what's going on. It was brought up about type 2 MI earlier as well, and this is where the full blood count comes in very handy. So there's a bloke on our ward at the moment who had some ischemic chest pain last night, some T-wave inversion and some ST depression. We thought he was all having an NSTEMI because the troponin was raised as well. It turns out that he was actually anemic. And what he's got is a type 2 MI. So that's when there's not a limitation of the blood to the myocardium by a blockage in the artery. It's when there's a lack of blood from hypoperfusion from somewhere else. So it might be that you're anemic and you don't have any oxygen in your blood anyway. So even if you're at rest, your blood doesn't have enough to supply your heart. It happens in sepsis quite a lot as well, where you might be in septic shock, your blood vessels are all dilated, and you can't get any blood to your heart, basically, and that's a type 2 MI. It's important to know about because we treat it slightly differently. So, for example, this bloke who's anemic upstairs, we have stopped his antiplatelets, we've stopped his anticoagulants because they're just going to make it worse. What you do, you need to replace his blood. So that's all about treating the cause, basically, in a type 2 MI. So hopefully that answers your question. So you've done your investigations, you then go on to your treatment. So this is what you do kind of as a junior doctor. An F1, you see someone, this is what you can do by yourself, basically. So firstly, you want to stop them being in pain. So what we give is IV morphine and metoclopramide. Metoclopramide is an antiemetic. We mentioned that you feel sick when you have an ACS, so you want to stop that. And morphine is also a drug that makes you feel sick, so you give them metoclopramide. You give them metoclopramide because it works it's an antiemetic that works by blocking dopamine receptors on your peripheral organs. So your organs release these chemicals like dopamine when they're upset and they're sensed by your brain, and they make you feel sick. Metoclopramide blocks the release of these dopamine and stops you from feeling sick, basically. So that's number one. Number two is GTN, so glycerol trinitrate. This reduces your preload. So this is a venodilator. So what it does, it dilates your veins, reduces the amount of blood going into your heart, so your heart has to pump less hard. And this reduces the oxygen demand on your heart. And you can either give this as a spray underneath the tongue, or if that's not worked, you can do an infusion. But you wouldn't be doing that yourself as an infusion. That's like a senior decision to make. But it's just something that you could suggest, or something that you can do if the sublingual GTN hasn't helped. Then you want to give them something to basically help with their blood clot that they might be having in their artery. So you give them some aspirin initially, and you want to give them another antiplatelet, but the precise choice of that comes later. So the initial one is just aspirin. And then lastly is oxygen. So there used to be an acronym called MONA, which was morphine, oxygen, nitrates, and aspirin. Now oxygen's only given if you're hypoxic. So if you have too much oxygen in an MI, it's dangerous because it generates free radicals, which then damages your heart even more. So you only give them oxygen if they're below their target saturations, basically. So a couple of questions, yeah, 300 mg of aspirin, yeah. So they get 300 mg of aspirin straight away, which is called a loading dose. And then every day after that, they get 75 milligrams of aspirin. So you just give them that big hit of aspirin straight away, basically. So that's your initial management. By now, you should have an idea of what's going on. You should have got an ECG, you should have got a troponin back. If you have the ECG and it's a STEMI, you can stop what you're doing and you just need to start treating that, basically, and they need PCI. If you've got your ECG, it looks a little bit ischemic, you need to wait for your troponins, which is lucky because unstable angina and an NSTEMI are treated exactly the same. It's less urgent, so you can afford to wait for your troponins. Then you just crack on with giving them the rest of the drugs before you do your PCI, and we'll go through what these are next. So we've done the immediate treatment. Now let's go on to a STEMI. So this is nice and simple, basically. This is the time frame that was mentioned earlier. So number one, the first question to ask is, did the symptoms start 12 hours ago? Does anyone know why there's this 12-hour cutoff, by any chance? Aspirin is the first treatment, yes, for unstable angina and NSTEMI, yeah. It's all the same in ACS, no matter what it is. ECG changes? Yeah, so the ECG changes might have stopped, which is kind of the underlying point of this. So basically, 12 hours is the amount of time myocardium can go before it's irrecoverable. You can't do anything about it. Even if you do PCI, you get the blood flow back, the heart muscle's just knackered. You've missed the boat, basically. So do you give aspirin in a STEMI or do a PCI? So you give them aspirin initially, then you give them another antiplatelet, which we'll talk about, and then you do PCI after. So we'll talk about the reasons behind doing each thing as well, which hopefully helps explain things. So yeah, 12 hours is the time frame for which heart muscle dies and there's no point recovering it. There's a little star because sometimes you can do it after 12 hours. And this would be if you've still got heart muscle that isn't dead yet after 12 hours. And this can be told by if you're still having chest pain after 12 hours. If you're still having chest pain after 12 hours, what it means is that there's still myocardium that's dying. So there's still some tissue to salvage. So you can consider doing PCI after 12 hours if someone's still having chest pain. But that's kind of very, very minor, basically. The second question is, can you get to a cath lab within 2 hours? I don't know why this time limit exists, to be honest with you. It seems a bit arbitrary. In the UK, most people will be able to. So I work in a district general hospital. We send people with STEMIs straight over to a big tertiary centre with a cath lab that's about a half-an-hour drive. So most people with a STEMI, the answer will be yes. They're within 12 hours. The platelet. So this might be one of ticagrelor, clopidogrel, or prasugrel. The ones that are used differ depending where you work. So I've not given like a specific one to know. Just pick one and learn it. Clopidogrel. It's nice, easy to remember. It's used in most other things as well. They get PCI, so they get something to blow into their artery, balloon it up, and fix the blockage. And at PCI, the cardiologist will give them something called unfractionated heparin, which is an anticoagulant and helps break down the coagulation cascade that's happened around that clot. So that's not something that you would give yourself, but just something to be aware of. If you've missed the 12-hour window, or you can't get to PCI within 2 hours, you can then do what's called fibrinolysis. So this is a drug given to break down the clot called alteplase. This is given in strokes as well. And it's basically the similar principle to PCI, but just with drugs, basically. It's less effective than PCI, and the bleeding risk is higher, which is why we don't do it very much. Because the bleeding risk is higher, you give them their second antiplatelet after they've had the fibrinolysis, because you want to make sure they're not going to bleed out, basically. And then the cardiologist will give them a different type of anticoagulant called fondaparinux, which is slightly less effective than unfractionated heparin, but as the bleed risk is higher, you want to kind of balance that out, basically. But this one on the right is kind of minor. Most people don't get that. This is on the left is what people get in the UK if you've had a STEMI, basically. Lovely. So that's a STEMI. Let's talk about unstable angina and NSTEMIs. So we mentioned that the management is less rushed, basically. It's not as urgent. So number one, you give them their second antiplatelet straight away. So again, clopidogrel, prasugrel, ticagrelor. Number two, you give them fondaparinux. So that's an anticoagulant that helps them break down the coagulation cascade in the artery. And number three, it's all about estimating who's going to die from their unstable angina or their NSTEMI to prioritize who gets PCI first. So everyone will eventually get PCI, but you want to work out who's at higher risk of dying, basically. And you do that with what's called a GRACE score. And just like SCAR, I don't know what's on it. The cardiologists never use it. They just kind of do whatever they want, basically, because they're cardiologists. I think they don't wrong with this sort of stuff. But for your exams, this is what to learn. So if you calculate this score on MedCalc or whatever, you won't be asked to recite it in exams unless your med school is really mean. And their risk of dying within a month is medium to high. You then do PCI within 3 days. At PCI, they get given unfractionated heparin by the cardiologist. That's not something you would do. They just get PCI within 3 days from your point of view, basically. If they're hemodynamically unstable, so they're shocked, their blood pressure's low, you can do PCI sooner, but that's very rare. 3 days is something to learn for unstable angina and an NSTEMI. If they are a low risk, so they're probably not going to die, then the risk of PCI outweighs the risk of them dying, basically, from an NSTEMI or unstable angina. So you leave them alone. You see them as an outpatient, and you can decide if you want to do PCI later or not. So that is an NSTEMI and unstable angina. What about streptokinase or TPA? Yeah, so TPA is autoplase. Streptokinase is an older drug. So streptokinase it's derived from bacteria that have similar, they basically have TPA in them. And the reason you don't give streptokinase is because once you've given it once, your body makes antibodies to it. So you can't give it again. So let's say you give them streptokinase for a STEMI, then they have a stroke next week. You've kind of buggered yourself, basically, because you can't give them any more streptokinase. So that drug's kind of in the past. We don't do it anymore. It's all about autoplase now. Okay. So that's our immediate treatment of ACS. So to make it nice and simple, everyone gets 2 antiplatelets. Everyone gets an anticoagulant, so fondaparinux or unfractionated heparin, and most people get PCI. Not many people get fibrinolysis, so I've left that out. They all just happen in different time frames depending on the clinical need. And that's the way to think about ACS management. It's all about who's going to die quickest from this sort of stuff. So that's the immediate treatment. We then had some questions about long-term treatments of ACS at the start. So these are really, really important. So this is what's going to make people live longer and better after they've had a heart attack. There's no point doing all your fancy stuff, going in and saving their arteries, and then they die 6 months later because they've got no heart left, basically. So firstly, you want to do an echo. So this is to see if some of their heart muscles died and see if they've got heart failure. Then you can start them on the appropriate treatments. You then want to start them on 4 different drugs. So these are really important, and these will probably come up in your exams. So number 1 is an ACE inhibitor or an angiotensin receptor blocker. These prevent your left ventricle from remodeling. So what that means is after it's died, the heart muscle tries to build back in a disorganized way, and that's bad. The ACE inhibitors stop that and leave your heart muscle as it is. And these increase your chance, these improve the length of time that you live. Number 2 is a beta blocker, so bisoprolol. This decreases the amount of demand from the sympathetic nervous system on your heart, so it beats less strongly and doesn't need as much blood to beat. And again, that improves your mortality. Number 3 is DAPT, so this stands for dual antiplatelet treatment. So this can be your aspirin and your second antiplatelet. You give both of them for 12 months, and after that, the bleeding risk of both of them starts to outweigh the benefit of both of them. So then you switch them to aspirin only for the rest of their life. And this stops the clot in their artery getting bigger and stops them clotting up again. And lastly, and this is the most important one, is a high-dose statin. So this is something like atorvastatin. This is the most important one because there's new research about that shows that statins stop your coronary plaques from bursting. So if you stop someone's statin, they're at a really high risk of having a plaque rupture. So statins are key to get into your mind, basically. And then there's some kind of smaller stuff, which is lifestyle stuff. So cardiac rehab, this is like exercise classes, which are really useful. Stopping smoking, living healthily, basically. So that's the long-term management of ACS. Yeah, 12 out of 12 DAPT is 12 months. That's just like the abbreviation. and DAPT is dual antiplatelet. Perfect. So that's the treatment of ACS. We've gone over the immediate stuff, what you can do, what the cardiologist will do, and then what we do after to help people live longer. Let's talk about some things that can go wrong after you've had a heart attack, because this is also really important. So you can split them up into different ways. I do it into things that are really bad. So firstly, this is stuff that kills people from a heart attack. As we said, your heart muscle can die and you can be perfectly fine. But if you have one of these things go on, basically you're toast. So you can have cardiac arrest. So your heart attack, your heart electricity gets messed up and you have a VF arrest or asystole and you die. Number two, you can have cardiogenic shock. So I believe this was covered yesterday by Dylan's talk. But basically this means your heart can't pump blood to any of your organs. Your organs fail and you die. And it's really hard to treat. We've seen some people with it on the ward and they don't tend to do very well. Your left ventricle can rupture. And this sounds bad, and it is really bad, basically. Blood will just flow from your left ventricle into your pericardium. You'll get tamponade. Your heart can't beat anymore, and you will die of cardiogenic shock unless you kind of draw the blood out, basically. And the little things in italics are just how to spot these clinically. And lastly, another bit of bad news is what's called a ventricular septal defect. So you might have heard about this in peds. You get a hole between the two ventricles. Blood flows from your left ventricle to your right ventricle because the pressure in the left ventricle is higher. And basically it means that your left heart can't pump out any blood because it's all going into your right heart. You get pulmonary edema, you get heart failure, and again, you will probably die. So that's number one, bad stuff that happens. Number two is arrhythmias and conduction issues. So these are really, really common. Basically, any arrhythmia under the sun can happen after a heart attack. You've messed up the electrical wiring. Arrhythmias are really common, especially bradyarrhythmias, so slow heartbeats. These are common after an inferior MI, because most commonly, remember we said that the right coronary artery supplies the inferior part of the heart. The right coronary artery also supplies your SAN, so your sinoatrial node. If you mess that up by blocking its electricity, your heart will beat slower. You get bradycardias, so like heart blocks and sinus bradycardia, basically. So too much to be said about them. And then these are the things that don't really fit into anything else. So pericarditis, very common, chest pain, ST elevation. You treat it with some ibuprofen, basically. Mitral regurgitation, so your mitral valve can rupture, and you get all the signs of mitral regurgitation. You get the same murmur as a VSD, so you need to do an echo. Dressler syndrome, which is kind of an exam favorite. It's not very common, but it comes up all the time because I think they like it because it's like a classical thing. So you get, it's like an autoimmune thing. You get high ESR, you get recurrent pericarditis, and you get pleural effusions a few weeks after an MI, and you treat it with some ibuprofen. And lastly is what's called a left ventricular aneurysm. So this is when you get a buildup of blood in your left ventricle, basically, and it presents with pain 4 to 6 weeks after an MI. You get ST elevation on your ECG, but it's there all the time, so it's not dynamic. And what you need to do, you need to give the warfarin to break down the aneurysm, basically. So those are the complications of a heart attack. So hopefully that all makes sense. We've been about an hour now, so let's talk about some cases. This is kind of our questions. I think this is stuff that we'll see can you use DOAC for what in terms of antiplatelet? Yeah, you can. Yeah, the evidence between warfarin and a DOAC is about the same. Some consultants use warfarin, some use DOACs. I wouldn't be making that decision myself, but yeah, you can use a DOAC. Yeah. So this is the first case. These are more like written down ones, so just have a think. There's no polls, so have a minute or so to read this. Lovely. Let's show you the ECG that the nurse hands to you. Doctor, here's the ECG. What are you going to do about it? This is what will happen to you guys when you're F1s, and it's really scary. So here's his ECG. And here are some questions. So he's got some central chest pain, 10 out of 10, radiating to the arms and the jaw. Give you the CCG. So, what is the diagnosis? Any suggestions? LAD, fantastic, fantastic. You guys are on it. You've clearly learned something. This is good news. So yeah, anterior STEMI is the diagnosis. Very, very good. And you guys have already pointed out the second question as well, which is that the pathology is in his LAD because he's got some ST elevation in V2, V3, and V4, which is the LAD. So he's having an anterior STEMI. So can we name him some drugs that we're going to give him in A&E? Yeah, metoclopramide, very good. Morphine, yeah. Aspirin, perfect. Circulating platelet. Aspirin, yeah, perfect. Unfractionated heparin, you wouldn't give in A&E. This is given by the cardiologists when they do PCI. So yeah, GTN is the answer, yeah. So GTN, morphine, dual antiplatelets, and then someone has correctly said oxygen only if hypoxic. So this bloke isn't hypoxic, so he doesn't warrant any warfarin, any oxygen, sorry. Yeah, metoclopramide is used for the sickness. Number one, you get sick from the MI, and number two, morphine makes you sick. So we just basically mess people up, but I'll stop that. There's no point fixing their LAD if he still feels like rubbish and he's still in loads of pain. He's not going to thank you, basically. And what is the definitive management of this guy's problem? PCI, yeah, fab. So as we can see, he's had it for about 2 days. He's had it for about half an hour. He can get to a centre. You've got a cath lab there because we live in civilization, and some PCI. If it was within 12 hours and he was still having chest after 12 hours, still got chest pain, you could do some PCI as well after 12 hours. Blow up the arteries, very good. Hopefully not like literally blow them up, but yeah, blow them up. An important thing to note that comes up kind of commonly when we're on the wards is that you can only do PCI on people if their arteries are partially blocked. So if you do an aneurysm on this, if you do an angiogram on this guy and his LAD is completely blocked, there's a complete blockage, it just stops. You can't PCI them. That's because you can't force a stent through a complete blockage. You're just going to basically mess up the artery and cause it to bleed everywhere. It's going to be bad news. What you would do there is a cabbage. So that's when you graft one of your veins from your legs or your lemur, your left internal mammary artery, around the blockage. You do PCI when they've got less than 99% stenosis. So when they've got a bit, you can basically like force the balloon through. So I think what the cutoff is 75 to 99% stenosis. But I don't think that's likely to come up in your exams, don't worry. Just be aware you can do PCI or cabbage, but PCI is in most people. So that's case number one. Case number two. So again, a couple of minutes to read this. Yeah, so PCI and angiograms are done if you work in a tertiary centre, so a place with cath labs, they're done at the same time because you need to see which artery is knackered before you decide which balloon to blow up. And if you work in a place like me, a district general, cardiologists do angiograms. They see which arteries are messed up, and then they send them over. That's in an end-STEMI or unstable angina. In a STEMI, it's a proper angiogram. So you basically want a proper angiogram is the gold standard for seeing your coronary arteries. A CT coronary angiogram is used when you have stable angina. Less risky, invasive angiogram. It's cheaper, it's quicker. It's someone there to do the angiogram. So it's used in stable angina. But when you've had a full-blown heart attack, you just want to have a good look at the arteries, basically. So hopefully that answers your questions. Anyway, hopefully everyone's had a minute or two to read it. So again, nurse gives you the ECG. Here you go, doctor, what's going on? So here's the ECG. You have a dig through the old notes and you find an ECG from last week which is completely normal. Just as a reminder, she's got some chest pain, her GTN hasn't worked, and her troponin is mildly raised. So yeah, you guys are already you're miles ahead of me, basically. So this is like a little bit of a two-step question, which you get in finals quite a lot. So what is the most appropriate management plan for this patient? So you need to kind of work with the diagnosis and then work out what you're going to do. Very good. You guys are like cardiologists already. You've sorted this guy out. So yeah, you don't know at the moment whether he's got unstable angina or an end-STEMI. That troponin could be raised because you're at the start of the troponin curve, or because they've got something else going on. I think I might have written in the case that they have got. No, I didn't. Let's say they've got CKD. Let's pretend that I wrote that in there off the top of my head. So yeah, you don't know what they've got at the moment. So you want to treat them as an end-STEMI or unstable angina, which is completely the same, with 2 antiplatelets, fondaparinux because they are hemodynamically stable, pain relief, morphine and GTM, and do a repeat troponin in 3 hours. Lovely. So, second part of the question. So you do a repeat troponin, and it comes back at 122. The previous is 104. Her GRACE score is low risk. Fondaparinux is an anticoagulant, so it's a factor 10A inhibitor, or it's a direct thrombin inhibitor. It works on a bit of the coagulation cascade that I learned for finals and then just burned out my brain the second after I walked out the exam hall. But you do it because you've got the coagulation cascade activated when you break the endothelium, so it helps stop the blood clot, basically. Wouldn't you give aspirin? Yeah, you give them aspirin as well. Yeah, so that's the dual antiplatelets. So the aspirin and the clopidogrel, ticagrelor, whatever. Lovely. Yeah, you guys are on it. So the most likely diagnosis is unstable angina. And the reason is because the troponin rise, as we said, isn't significant. It's not 50% higher. This would be used in my labs. They've probably got some other going on that means their troponin is raised forever. So you can safely say that they've got unstable angina, they've got some ischemia on their ECG, and they've got some significant troponin rises. Factor 10 inhibitor, there we go, this, you know much more than me, there we go. And the definitive management, perfect, you guys are all absolutely spot on. So they don't need a PCI right away. The risks of a PCI will probably outweigh the risks of them having a death from their unstable angina. So you do their medical management. So the medical management is just here. So you do your 5 drugs, your 2 antiplatelets, aspirin, ticagrelor, clopidogrel, whatever. You do your beta blocker, you do your ACE inhibitor, and you do your high dose statin. Okay, and they're the drugs that are going to sort people out. If troponin does not rise very quickly, does that mean it is unstable angina? Yeah, so this is where troponin is tricky. So we mentioned how ACS is very clinical in the diagnosis, basically. So the kind of catch with troponin is that you have to interpret it in the right clinical context. So let's say this lady had no chest pain, their ECG was normal. You did a troponin because you're just mad for some reason and it was raised. So you've got to do another one in 3 hours because you just made yourself more work. And it's high. That is not the right clinical context for ACS. What you need to do is interpret it within the clinical context. So this lady has chest pain that sounds ischemic. She has ECGs that look ischemic, and she has a troponin that is a little bit raised. So in that case, you can kind of safely say that she is having a cardiac event, but it's not on end-STEMI because the troponin isn't raised. If she wasn't having any chest pain, wasn't having any ECG changes, then yeah, it would definitely be due to other causes. And also, I guess the unstable angina, the troponin is still raised because of the other causes. It's the lack of troponin rise. That means it's unstable angina, if that makes sense. So you want to question, so if this lady has chest pain and troponins are raised, I think, yeah, exactly, perfect. Would you not do repeat ECGs? Yeah, you would. So in this case, you want to. What happens on the ward quite a lot is people who have got knackered coronary arteries have this sort of chest pain. You do an ECG when they're having the chest pain, and it looks really bad like this, and you get worried. Their chest pain goes away. You do another ECG, and the ECG returns back to normal. That is what we call dynamic changes. So it means that there's been some sort of blood supply issue to the heart over a couple of minutes while they've been having the chest pain. You get the ischemic changes. Their chest pain goes away when their heart supply is better, and the ECG reverts back to normal. So perfect. You would want to do serial ECGs.